Brilliant. Thank you. Well, thank you for the introduction. And it's a real honor to be here today, especially as you were saying, as someone who graduated from this master's not too long ago. It's really amazing to be back here. And I'd like to start by congratulating everybody that is graduating today and the new cohort that's starting this adventure. Today I'll be presenting, as we were saying, some work that we previously did. So I'm now working for the Clinton Health Access Initiative in Central America and Hispaniola. But I'll be showing a little bit of the work we did in Bangladesh. And the question that we'll be talking about in this presentation is the question at everybody's lips: is overcoming climate change impacts possible? And to do this, I'll be presenting a case study on high indoor temperatures, where we'll be going through a few different steps. So first of all, how we worked through the hypothesis, how we saw if the magnitude of the problem was as big as we thought, and then some of the solutions we were able to find. But before we talk about that, I really wanted to highlight here why it's important to talk about One Health when we look at climate change impacts. And we've had a few presentations today that have been talking about this. But really what I want to highlight here is how climate change health impacts never affect only one of the bubbles. I'm going to put my laser here so we can talk about it. So it never affects one of these bubbles, right? We're always talking about it affecting either human and animal health or animal and environmental health. And I put some examples here. So for instance, how we have now malaria in the US. We've had some cases of malaria in the US because of vector changes, but also increased globalization. Then the impacts of human behavior. So with increased global warming, children are known to go to school earlier, as the tarmac on the wall, on the floor, can be burning their feet sometimes, and that makes them more prone to have contacts with snakes, increasing the number of snake bites that we see in certain contexts. Also, in terms of biodiversity loss, so we know that as biodiversity is lost, there is more contact potentially between animals and humans, leading potential outbreaks like we saw for the Ebola. And lastly, with the conflict-affected states that we were talking about before, and flooding, sometimes when we have increased floods, we can see there's more diarrheal diseases, and this is the environment being deteriorated, leading to increased health burden. But so in this context, really what I wanted to focus today is on, is there anything we can do about it? And here I'd like to present the framework of climate and health resilience. So climate and health resilience is a way of looking at the effects of climate change and trying to understand whether there's anything we can do upstream or downstream to reduce its impacts. So when we talk about mitigation, we really are talking about tackling the causes. So everything to do with reducing emissions, making the actual magnitude of the problem smaller. So we're reducing emissions, we're shifting to renewable energy, sustainable transport, healthy diets, basically reducing the emissions and making global warming hopefully less bad. And then the other part is adaptation. So once we have the problem in our hands, is there anything we can do about it? And here we're talking about things like heat action plans, putting cooling systems in cities, and climate health resilience, where we prepare the health system to have the right doctors, the right nurses trained with potential challenges that could come from health diseases. Or vector control and surveillance, having a good idea of the vectors that are there so that when we have an outbreak, we know how to tackle it. Or urban planning for resilience. So we could think of mitigation as tackling the root of the cause and adaptation tackling more the causes. And so here, moving to the case study we're talking about today, really we were interested in high temperatures and how high temperatures affect health outcomes. So we looked at literature and we saw that this is indeed a reasonably well-known fact. High ambient temperatures affect health outcomes, and both in high-income countries, middle-income countries, and lower middle-income countries, where we have things like heat stress and heat-related illness, increased respiratory hospitalizations, but also changes in how vector-borne diseases are managed and others. But the question we wanted to answer here was related but a little bit different. We were interested in understanding indoor temperatures. And this is because outdoor and indoor temperatures are related, and especially so in places without heat mitigation. So you can think of heat mitigation as your AC that I've got on right now here in Panama, or a fan, or even windows, ways of modulating indoor temperature for it to be lower than outdoor temperature. And this is important because in many contexts, the majority of people's time is spent indoors. So here we really wanted to know, do high indoor temperatures affect health outcomes the way we know that high indoor temperatures ambiently affect health outcomes? And so we did this in Bangladesh, so the only fragile conflict state that is one of the top 10 countries affected by climate change. Bangladesh has a very high population and very high density of people. So we have almost 170 million people living in a country that is a quarter of Spain's size. So almost 4 times more people than in Spain in a quarter of the size. So you can imagine how densely populated it is. It's a lower and middle income country with a poverty rate of about 20%, and most of the people follow Islam. Fertility rate and vaccination rates are some of the health outcomes that have improved massively in the last few years. So changing from 3.5 births per woman in the 70s to almost 2 currently. And the majority of children, one could say almost 90%, are vaccinated and receive all recommended vaccines. These are really good health outcomes. But there's something that is potentially challenging this, and that is climate change. So as was presented previously, Bangladesh has been consistently in the top 10 countries most affected by climate change or at risk of so for basically all of this millennia. And this is for a few different reasons. Firstly, the country, a lot of it is at sea level, which means that a rise of level of sea could mean a lot of the country would be submerged. And this leads a lot of people to be climate displaced, a lot of which would move to high urban metropolitan areas like Dhaka or other cities. Currently, 36% of people live there. By 2050, it's estimated this could rise to 60%. And you can imagine this would lead to crowding and slums that are already very crowded being more so, and possibly a lot of other health outcomes. I put this graph here to highlight how this is potentially going to go in the future. So it's been around 30 degrees since we have health records, temperature records, sorry, and then we really can see how depending on the different climate forecasts, we will see different rise of temperature. So Bangladesh can be said to be a country that it will be highly affected by the rise of temperatures. And so what did we do in this case study? Well, we did a longitudinal study in a few different places, but I'll be presenting today the work we did in Chakuria. Chakuria is here, and it looks something like this. It's an urban area very close to the sea. And what we wanted to look at is how temperatures indoors and outdoors are related, but also how these affect health. So we could install data loggers indoors and outdoors, and we also gave monthly questionnaires to have an idea of how people's relation with health changed and how their behaviors changed with heat as well. And so to dive into this a little bit more, we put these funny devices, which are health loggers or data loggers, and with these measure temperature and humidity every hour. So every hour we could have an idea of indoors and outdoors what the temperature and humidity looked like. And with this, we could calculate something called heat index. And heat index is a much better approximation of how heat feels in the human body than just looking at temperature or humidity individually. And then we went to Chakuria. And here's a map of Chakuria, which we divided in different zones. And we went to 49 different villages and installed these data loggers, both indoors and outdoors, to have an idea of how the temperature was changing. We also wanted variation in the types of households that we chose and the types of settings. So we chose houses, restricted them here to bamboo and cement. And if we move to results here, we saw that the magnitude of the problem was indeed quite big. So in terms of perception of the people, we saw that almost everybody that was interviewed reported being uncomfortable in the heat at some point. And in terms of the temperatures indoors, we saw that more than half were above danger threshold. These are thresholds that vary depending on settings, but the danger threshold for this area was around the one you can see here. So you can see in orange. And this means that either the temperature was very high and humidity was low, or humidity was very high and the temperature was a bit lower. So 50% of the days were above danger threshold indoors, and 7.5 days were above extreme threshold, which meant that really the magnitude of the problem was quite high. And then we went, okay, well, we know we have high temperatures indoors. Does this affect health like it affects outdoors? And we saw that indeed, hotter houses reported more illness. So hotter houses reported significantly more cases of diarrhea, local site infection, and sore throat, amongst others. But these were the most significant ones. And so when we moved at this framework and looking at what interventions we could do, we really analyzed it the following way. So we have we've confirmed we have high indoor temperatures. Okay, this is a problem. And then we think that this could be linked with more cases of illness. But what could we do? We didn't want to just stop there. We really wanted to see whether there's anything we could do to reduce this problem. Well, the obvious one would be, okay, let's prevent global temperature rise. Let's force every country to stop emitting CO2 or whatever is necessary and make sure temperatures don't rise anymore. This is obviously not necessarily super possible for a small research group. And so we looked at some other things. We could improve housing. Improved housing could potentially lead to the indoor temperature being less than the outdoor temperature, or at least a little bit lower. Or we could also provide coping behaviors, give behaviors to the people that are being affected by these high indoor temperatures, suggest things that they could do, and hopefully cut the transmission between high indoor temperatures and more illness. So really here looking at improved housing as a mitigation option for reducing the magnitude of the problem, and coping behaviors as an adaptation mechanism to reduce the context and the response of the problem to illness. So let's talk quickly about what we did in these two. Part one, mitigation. So really what we wanted to look at here was, does housing affect indoor temperatures? And is there any characteristic in a house that we could suggest or look at that would lead to this problem being less big? So we looked at wall material, we looked at shading, and we looked at some other factors like having a false ceiling, which is something that you see here, distance to the sea, and some others. And the key ones that we found had an impact were shading and wall material. So really what we were able to see was that the heat index, or the perception of heat in the human body, was less in those houses that were surrounded by shade, or at least had some shade. We also saw that this led to less reports of illness. So houses that had some shade or a lot of shade reported less illness than those that were not shaded. And this potentially could be linked to temperatures, as those that had some shade or a lot of shade showed less temperature indoors than those that had no shade. We saw something similar for wall material. So those houses made of bamboo compared to cement had higher indoor temperatures. And those that were made of cement also led to less reporting of illness, which means that potentially cement houses could be protective for not only reducing indoor temperatures, but also feelings of illness. Then we looked at the second options, adaptation. So we knew that this was an option, and then we looked at some other ideas. So adaptation. Adaptation really is about providing to the people who are affected different behaviors or different factors that one could do to reduce the magnitude of the problem, reduce the consequences in this case. So here we looked at a few different things, and I'll highlight just two. The first one we looked at was the storage of food. A lot of the cases that we saw of increased illness were things like diarrhea. And we know that storing food outside can lead to a higher propagation of microbes, leading to more potentially feelings of diarrhea. And so what we found is that a lot of people, despite having fridges available in about 30% of the households, the majority of these didn't use them. Only 20% of people who had a fridge used it to store food. A lot of them used the food outside, just covered. And in terms of behaviors, we saw that the majority of people, and here we looked specifically at women, the majority of women actually did know the behaviors that one should use. So they knew that showering could reduce temperatures or the feelings of temperature. They knew that turning the fan on or drinking more water would help, but they weren't always doing them. And let's talk about why that was. So in summary, can we say that there is a possibility to overcome climate change's effects? My answer would be the yes and no. Obviously, mitigation and adaptation are things that we're doing from a health perspective to help reduce the impact of health due to climate change. However, climate change won't be overcome by doing mitigation and adaptation on health consequences, and reducing emissions is absolutely crucial. However, if we're looking at how we can mitigate and adapt our behaviors so that the health consequences are less big, there are some things we showed we could do. So focusing first on mitigation. So we looked at specifically improving houses. Obviously, there's a lot of other ways we could look at mitigating this effect. We focused on this one. Here we looked at wall materials. So we saw that bamboo indeed wasn't great for temperatures. It caused higher indoor temperatures, and it's also very vulnerable to sea level rise, meaning a lot of people have to rebuild their houses reasonably often. Then we also looked at shading. And shading did play a role in reducing indoor temperatures, likely linked to roof material. Roof material was consistently tin in all these houses, which meant that a lot of people could have had increased temperatures due to this tin roof. And we saw in another part of the study that indeed this did play a big effect. And some other mitigation factors have been done, like painting roofs white. And the second thing we looked at was adaptation, and specifically looking at protective behaviors. So we wanted to know whether people knew these behaviors, practiced these behaviors, and if there were any factors that meant they couldn't do these behaviors. In terms of knowledge, most people knew the behaviors that they should do. In terms of practice, these varied. Some people were very happy to do the behaviors that they were looking at, and some really didn't. And a lot of times, the reason that there was this discordance between the knowledge and the practice was environmental factors. For instance, while people knew drinking more water was beneficial and would probably lead to less feelings of illness and heat, they didn't necessarily do so, as they felt that the water they were drinking was unsafe. So sometimes, while knowledge and practice are not discordant, it's often due to environmental factors. And this is why we really have to be maximizing intrinsic knowledge. Certain factors that were protective were not acceptable by the communities in the study. For instance, one recommended factor is adaptive behavior, is removing clothing or wearing lighter clothing. But like I presented, most of the communities we were working with were Islamic, and that was not an acceptable behavior for these people. In terms of housing adaptations, while many housing adaptations are recommended in literature, when we suggested these or explored these possibilities, they were not feasible. For instance, adding windows is something that is recommended to increase airflow and decrease indoor temperatures, but people responded that they felt unsafe by having windows open, or they didn't like them because of noise and pollution. So this really highlights that the context of where you're doing the research really matters, and not all solutions are transferable. So while a solution could have been applied and worked well in certain contexts, we really need to be applying these at a local level. And research needs to be localized like this. We need to be informing our hypothesis directly by the affected communities. And this is where we're moving from a top-down to a bottom-up approach. A top-down approach where we look at hypotheses elsewhere and we test them in affected communities. And moving more towards a bottom-up approach where we co-create or we listen to suggestions of people that they already have, solutions that they're already working with, and then we can test those. And this is increasingly important. So going back to the graph that we showed of Bangladesh, these are the different heat temperature changes that we could see depending on emissions in the coming years. And this year has been key for global health for a bunch of different reasons, but I'll highlight just two. The first is withdrawal from the Paris Agreement. The US government has withdrawn from the Paris Agreement, meaning the second biggest contributor to world emissions has now no longer committed to reducing them. This means that we are at risk more than ever out of this increase of temperatures. And we also have had USAID cuts, either directly or indirectly, we've all heard about them. And highlighting just the climate change grants, we can see here how 98% of them have been terminated, which means that a lot of grants working on mitigation or adaptation of the consequences of climate change are now no longer going through. And these were things like technical assistance to address habitat loss and fragmentation that could prevent the next outbreak, but also direct effects due to mudslide prevention in Rohingya camps of Bangladesh, which is already shown in this year to increase number of deaths. In this context, it is more important than ever that we stay as connected as possible and we work not in silos, but really take the One Health approach of working together, really cooperating and sharing research and really making sure that we learn from each other. Not by taking one thing and implementing it everywhere, but taking learned lessons that we've learned in one place and testing it elsewhere. One Health really helps us focus on prevention and building resilience. And these are key topics to think about right now, as climate challenges are here to stay, but there are things we can do about them. One quote that I love and I really think about quite often, someone told me, is climate change is like taking your phone and looking at a video, and that video becomes closer and closer of a disaster, so a flood, and it's closer and closer until you're the one recording it. And in that context, really staying connected and working together is what One Health teaches us and what we really should be applying. And with that, I'd like to thank everybody that contributed to this research, and I'd love to answer any questions if there are any. Thank you.
Thank you very much, Alba. What an interesting presentation, and quite alarming, that last statistic that you shared about the funding cuts. Is there anyone in the room that has a question for Alba? Online? Okay, in the interest of time, it seems that maybe we'll have to go, but we'll collect any questions that may be coming in from in person. Thank you.
Amazing. Thank you. Thank you for having me. And congratulations again.